So my name is Michelle Weiner. I am an interventional pain management physician. I work with Spine and Wellness Centers of America. We're a pretty large pain practice in South Florida from Palm Beach to Kendall. Today talking about therapeutic uses of cannabis. We try to focus more on wellness in our pain practice, and I hope you get that gist today. Carlos, it's funny because Carlos is a friend of mine. After I took the 8-hour CME course, the first thing I did was called Carlos because there's a lot that we don't learn during that course, and he actually led me to a lot of people who have educated me over the past year. So today we're going to review the history of cannabis. We're going to talk about physiology and the endocannabinoid system. We're going to review some literature, talk about the impact on healthcare, and then the patient-doctor relationship and the doctor's role. So cannabis has been used for thousands of years throughout different cultures for different disorders, anxiety, insomnia, seizures. It was in the mid-1900s that there was a significant decrease in the education, and this was mainly because of the Marijuana Tax Act, which then, when they determined that cannabis was a Schedule I drug in 1970, there was a decrease in education and research. So in order to be Schedule I, which is like heroin, cocaine, LSD, there has to be no medical use, it has to be abusive and lack evidence. So because marijuana is still a Schedule I, there's a lack of ability to do research, and it makes it very difficult for clinical trials on humans. The endocannabinoid system was discovered in the mid-1980s, early 1990s. So people are using cannabis, and there's physiological changes in the body. So a guy named Meshulam in Israel and a lot of other people were looking into why this is so. They decided that this system is really about balance. It's about homeostasis. It affects many of our systems throughout the body. Perhaps some deficiencies may be actually a deficiency in your endocannabinoid system. Maybe people need cannabis daily. Maybe they need it just to maintain their homeostasis. So these are some landmark discoveries. In particular, most important things for non-medical people, and I kind of look at you guys as all potential patients, or you may have family members that are in need of this. So it's good for you guys to understand the science and be passionate about it for yourself or for family members. So in the early 1990s, they discovered there are CB1 and CB2 receptors. These receptors, CB1, are in the central nervous system, mainly the brain and other organs. And CB2 is mainly in the periphery. It's for immune cells, for your tonsils, your spleen, different organs in your abdomen, and there are ligands. There's endogenous cannabinoids. So if you use cannabis binds to your CB1 or CB2 receptor, but then they discovered there's actually an internal system, and there's endogenous cannabinoids in our body called anandamide and 2-AG that are always working since we're born for maintaining our homeostasis. Not to bore you guys too much, but pretty much a gist of the physiology. You have the CB1 and CB2 receptors, different locations throughout the body. They are made from these phospholipids, and they're in all of our systems. They are produced as we need them, and then rapidly degraded into inactive substances. And they are different from other substances because they act with retrograde suppression. So basically, they work on the postsynaptic neurons. So you see the EC is the endocannabinoid. That is basically binding like a lock to the CB1 receptor, which will cause GABA to increase and a lot of other neurotransmitters like dopamine, serotonin to increase. That can affect your mood, but it's a different system. It's a postsynaptic system. So there are many cannabinoids within cannabis. There's over 100 substances. It's not just THC and CBD that everybody hears about. There's many different types. And when, as a physician, and in the future in Florida, we hope to personalize and individualize cannabis so that you are able to pick the right profile. And it's not just THC and CBD. And there's tons of research on all of them, and they all have different properties. Many different types. So they were talking before about CBN, maybe good for sleep, or CBC is an anti-inflammatory. So there's more than just CBD and THC. In particular, this is what we know the most about. This is what's available for Florida right now in the dispensaries. There's a lot of evidence about the ratios and different profiles, and as the dispensaries evolve, I hope that what's available in terms of cannabis will evolve as well in Florida. To differentiate, CBD is the non-psychoactive. So THC is known as the substance that causes more of the euphoria. CBD has many roles. One of the best roles of CBD is to mitigate the negative effects of THC. So a lot of times people use THC and they don't like their high, right? The point of CBD is actually to decrease the psychotropic effect of THC. And besides it being a great anti-inflammatory, anti-anxiety, very safe, but it does help out with the negative effects of THC, which is important, which is why when you have something like a synthetic drug like Marinol that's just THC, you're missing the CBD component, you're missing a lot of other components. THC, it has a lot of great properties. It's antispasmodic, anti-neoplastic, analgesic. It's known for decreasing nausea with chemo patients and also increasing appetite. So they have a similar onset. Obviously, inhalation or sublingual would be a faster route, as opposed to edibles ingestion could be an hour or two, depending on the person, could be longer. The half-life is different, though. THC's half-life is 7 days, and CBD is much quicker. So an important part to note is that I do believe it's very safe, but you have to understand that it also works with certain enzymes in your body that other drugs work on. And so it's not that, for example, opioids, maybe they use the cytochrome P450 or 3A4. What happens, it's not that you're getting more high from the THC, but it's actually increasing your opioid bioavailability. So you're actually getting high from your opioid. So there is a lot of drugs that do interact that you have to be careful. Okay, the medical benefits. Obviously, this is a picture that shows that multiple cannabinoids have multiple effects. I'm a pain management doctor, and I think in the United States, lots of people have pain, especially in Florida. Lots of people are on opioids. I just wanted to review so you understand there is a lot of science, a lot of evidence about the physiology of pain management and the use of cannabis. So it's not just that it's a great anti-inflammatory or that it makes you in this different state of mind that you're able to forget about your pain. There's actually lots of evidence showing it works on TRPV1, it works on the dorsal root ganglion to inhibit the pain signals, and there's a lot of evidence showing that the things like fibromyalgia, chronic fatigue syndrome, these disorders that have no true etiology. You can't do a biopsy, you can't do blood work, you're not going to find anything. It may actually just be a deficiency in the endocannabinoid system, and there's a lot of evidence showing this. This is a huge slide showing the multiple systems within our body and how the physiology, for example, let's talk about the GI tract, colitis, Crohn's disease, irritable bowel syndrome. There's a lot of evidence showing that it can suppress GI motility, decrease intestinal secretions, reflux. For dementia, for example, it is known as a neuroprotectant. It can actually inhibit the aggregation of amyloid plaque, which is what is the cause of Alzheimer's in particular. And PTSD is an interesting one. So there's effect on acetylcholine, and this affects your memory. What's funny is that we're always talking about memory, but you can also think about the ability to forget. So for example, if I'm looking at all you right now, And I had to remember all of your faces all day long, or you're walking and the ability to forget is such an important physiological ability that we don't think about on a daily basis. But the fact that it does affect your memory can also be therapeutic for certain people, for example, in PTSD. Mood and depression, it can be an antidepressant. It affects your dopamine and serotonin neurotransmitters. And for cancer, it's been shown to induce apoptosis, which is programmed cell death, and inhibit angiogenesis, which basically gives blood supply to tumors, can inhibit metastasis. Lots of things. Glaucoma decreases intraocular pressure, and osteoporosis is a big one because it actually can increase your osteoblasts, which form bone, and decrease the osteoclast activity and cartilage loss as well, and can help with bone healing. So literature review, if it was like 2 months ago, I probably would have had a lot more slides and different presentation, but there was this huge article that came out, 396-page report looking at 10,000 research studies, and they found 100 different conclusions, and they broke it down into substantial evidence, moderate evidence, and limited evidence. And so this is basically just a review of the evidence. So the review of what is out there in the literature. So they found conclusively that there's substantial evidence that marijuana treats chronic pain, nausea and vomiting in cancer patients undergoing chemo, as well as spasticity and multiple sclerosis. So there's conclusive and substantial evidence in the literature for those. In terms of smoking marijuana, it's not associated with lung, head, or neck cancers. And there's moderate to limited evidence that marijuana is therapeutic in insomnia, increasing appetite in HIV/AIDS patients, decreasing anxiety, and combating PTSD. They also looked at the risks. So there's evidence that regular marijuana smokers are more likely to have chronic bronchitis. However, this can be reversed when they stop smoking. And this is again on smokers. So right now, we can't actually recommend anything that's besides, vapor, pills, oil. There's no smoking. So this is evidence about smoking. There's evidence about a link with prenatal cannabis exposure and low birth weight. There's a lot of evidence showing that a lot of these patients are also using tobacco at the same time, and this can be a confounding variable there. And in terms of schizophrenia, there's a lot of controversy with psychiatric disorders. So they said it's not clear whether there's evidence showing increased risk of developing schizophrenia, but it's not clear whether these patients were turning to marijuana as self-medication. And there's also a difference between a link and a correlation versus causation. It's not that marijuana will cause schizophrenia, but there's a link in the use. So the bottom line is that a lot more research needs to be done. The problem is it's a Schedule I drug. Now speaking about, so we talked a little bit about endogenous cannabinoids in our body. We talked about, obviously, phyto, meaning medical cannabis as the plant. What's available in terms of synthetics. So if you're a physician, you can prescribe Marinol or Sesamet, which is for AIDS or chemo-induced nausea and vomiting. There's Sativex, which is not available in the US. This is actually one of the only THC, CBD combinations, and that's for muscle spasms and MS. And then what's interesting is this one, which is for the treatment of obesity. So if you think about it, THC causes an increase in appetite. So if you're gonna block the CB1 receptor, which is where THC binds, you would think it would cause weight loss. The biggest side effect is obviously going to be nausea. So you're gonna, it can possibly help with obesity, but the patient's probably going to be nauseous all day long. So the bottom line is there's something called an entourage effect. The entourage effect basically says that the whole flower, the plant itself, is really the most beneficial because you have all of the cannabinoids. It's not just the THC or the CBD, you have everything together working in synergy to help with many different symptoms. Impact on healthcare. So let's first look at opioid use, okay? So in the states that medical marijuana is legal, over the course of 5 years, there's been a 30% decrease in opioid fatalities. That's a huge number. There's 80 people that die every day from opioid use and 200 million prescriptions, opioid prescriptions that are written in the US. There's been not one death from the use of marijuana, and this is because the receptors, the CB1, CB2 receptors are not in your brainstem. They're not where your respiratory drive is being controlled as opposed to opioids. In terms of addiction, there's been evidence that there's a 9% rate of addiction. Now, this is a very overinflated number, and the reason why is because, first of all, say you were arrested for possession of marijuana or using marijuana. Perhaps the judge says to you, do you want to go to an addiction treatment center, or do you want this other punishment? So then all these people who use marijuana go to an addiction treatment center, and there starts the increase in this addiction rate number. Also, maybe they're using it for medicinal reasons. So there is this increase in dopamine, which gives you the desire to want to use it, but it's not an addiction in the sense that if you stop, there's no withdrawal effect. There's no harmful side effect. There can be tolerance to cannabis, and then you can maybe switch the strain. But in terms of addiction, I think with cannabis, you still need to use it in moderation, but it's more of a desire and a treatment than a true addiction. There's also lots of evidence that they're using it for opioid withdrawal. So people who are on opioids, who want to stop using opioids, they have a lot of uncomfortable symptoms. And marijuana actually can mitigate a lot of these symptoms. It's probably not going to be accepted in the addiction world right away, but it could be a good option. Bigger studies, just in general, a lot of the studies are not on humans. A lot of them are these retrospective studies that in the states that it's legal, for example, there's fewer traffic fatalities in medical marijuana law states. There's also a decrease in the prescription drug use that estimated to be $468 million decreased annually in drug spending. There's evidence showing that marijuana use is associated with better in-hospital survival rates. So patients who are, for example, cancer patients, they actually are, their mortality rate is decreased in the hospital. This is funny. I walked into my mom's house the other day, and she had this magazine, and she's a member of this organization. The point of this slide is to say that there's been a 250% increase in the use of cannabis in the 65 years and up. So those are the patients that I'm seeing. I'm seeing the patients who are older, who are saying, I've tried everything, I've had side effects, I can't use this, I want medical marijuana. And it's usually this population. Okay, so the physician's role. Physicians, my main goal is to figure out what the objective, what am I treating? What does the patient want to, need assistance with? And obviously as physicians, we are patient advocates. We want to educate other physicians. We want to educate the patient. But we want to know, is the patient having difficulty sleeping because of pain? So do I need to treat the pain? Do I need to treat the sleep? Do they have a specific disorder? Are they having these symptoms because of an endocannabinoid deficiency? You want to know the objective. Then comes the dosing, the strain, the delivery system. Do you want something that's short acting? Do you want something that works immediate? And you have to know their previous history. Have they ever used cannabis before? And any psych history? What's their intention? What's the objective? And then monitoring is a big deal. So there's a lot of issues and frustrations. The 3-month relationship is the most absurd thing. I have terminal patients in the hospital that will probably die before that 3-month relationship, which means that, it's not even an exception if you're terminal. You still have to wait the 3 months. I could give the patient any opioid in the world, but I can't give them medical marijuana. Access is a problem. If there's 7 dispensaries right now, and only a few of them have maybe high THC, and some of them are running out of their oil, and patients, I'm giving a patient a recommendation for something and they're getting something else from the dispensary because the dispensary ran out. The cost also is a big issue. The 8-hour CME class has to be adjusted. It has to be more beneficial for the physician so that when we finish the course, we're able to not call, friends and we can actually learn during this course. And then also as a physician, you have to be passionate about this. You want to help the patients in the right way. You want to advocate for them, and you want to educate yourself. It's not something we learned in medical school, so we all need to keep educating ourselves. Telemedicine's another topic. I think that in terms of this telemedicine, there's a lot of patients that maybe can't get to your office. There's a lot of patients that are very sick. However, I think you should at least have one visit with the physician to do a good physical and history before you can do telemedicine and follow up and monitor. And then pre-qualifying for physicians, are they doing that online, or people sending in medical records and they're pre-qualifying them? Do they need a visit? So there's a lot of questions as a physician, if you want to start doing this, to think about before you actually initiate the process. So this is my last slide. The bottom line is lots of research needs to be done, but there's a lot of evidence already. I think it's funny that the US has 5 patents already on cannabis showing, and it's still a Schedule 1, showing it's useful for nausea and vomiting, it's an antioxidant, it's neuroprotective, anti-inflammatory, cancer, apoptosis. So I just wanted to leave you with that, because the most important thing is really, for me, education and advocating for the patients. Thank you.